So, good evening. Thank you and welcome for joining us today. I'm going to hand over to Mr. Mohammed for the talk today. Thank you, Mr. Mohammed.
Thanks. So macular edema, I'll put it on slideshow, one sec. Well, or if I can get it on slideshow, there we go. Yeah, macular edema is about as general and broad as you can get for medical retina. There's not many things that the retina can do. It either gets neovascularization, it either bleeds, or either swells, or scars, or eventually becomes atrophic. So it's just trying to tease out, it's all pattern recognition ultimately. So we're just going to go through the various causes. As usual, there's a few major causes which account for the bulk. And then there's a few minor things which are rare and you may think, why on earth are we going through them? But it's just to really have that structure in your mind as to what the correct approach is for looking at these things. And again, when we sort of set up these sessions, it was really primarily about OCT interpretation. Where, I know many of your practices will have OCTs now. So the focus very much is OCT driven. It's really just about teasing out minutiae on an OCT scan and then trying to make sense of what those findings mean. So in terms of the normal retina, we're not going to go back to the basic physiology of this, but let me just take this thing off my screen one sec. Yeah, we're not going to talk about the whole basic physiology, but the homeostasis of the retina is really important. It's a really tightly regulated, very finely balanced entry of fluid and exit of fluid, and there is a continuous cycling, obviously, to deliver metabolites, oxygen, proteins, and the rest of it. So there is this very basic principle of physiology called Starling's law, which is fluid coming in, fluid going out. And what drives fluid going in primarily is hydrostatic pressure. So that's the arterial blood pressure. But remember, blood is water, proteins, cells, and that has an osmotic pressure as well. So what drives fluid out is the hydrostatic pressure. That's the physical force, arterial blood pressure. Obviously, it peters off when you come to the capillaries. And then what draws fluid back into the venules is the oncotic pressure, which is osmosis, drawing fluid back into the retina. So that's really basically it. Fluid goes out and then it's sucked back in again. And it's got to be really tightly maintained to maintain that tissue transparency, light transmission. And whenever the tissue swells or becomes disrupted, whether it's exudate or hemorrhage, then obviously light transmission to photoreceptors becomes impeded, and then that will translate to suboptimal vision. So, of course, the symptoms are like every retinal disease, blurred vision, metamorphopsia, anything distorting the retinal surface will impact on how the brain perceives changes. Micropsia, some people may describe that. That's a sort of classic symptom of CSR, but in actual fact, most conditions that swell the macula will cause that. Central scotoma, that can be very difficult to judge whether that's relative or full. It all depends on what's causing the problem. And then, of course, the things we don't check, contrast and color sensitivity. But these are the real more important features of visual function. It's not just about visual acuity, black on white. That's not the real world. The real world is depth and contrast and color and subtle shading. And this is what people really notice, particularly with early onset disease. And it's a problem because actually 80% of our clinic is clogged up with some form of macular edema or other. So there's a huge health burden associated with it. The drugs we're using now are increasingly more expensive. It drains a huge amount of resources and manpower. It's inconvenient for the patient, obviously having to turn up to the hospital regularly for scans and injections and treatment. And of course, all the treatments we've got for most forms of macular edema, if it's sight-threatening, is risky. It's not just the cost, but every injection has a risk of potentially causing blindness. And, we always feel terrible about it when someone's vision is reasonably well controlled. It doesn't happen very often, but if someone gets endophthalmitis and they lose vision for something which was well controlled, you always ask that question, did they really need the treatment anyway? So that whole definition of edema is just an abnormal increase of fluid volume, and it's extracellular fluid. So fluid is either in the cells or outside the cells, but the retina and brain are very, very tightly regulated, very highly metabolically active tissue. So this is fluid seeping into the space between cells. That's the extracellular fluid space. But there's a sort of general principle that the first thing that happens is the retina diffusely thickens, and then you get little pockets, so-called cysts. They're not actually cysts because the histological definition of a cyst is something which is lined by cells. So these are just cavities within the neuronal tissue. So things have just been spread apart. The cells are still intact and communicating, but you can imagine how nerve tissue, which is supposed to be very tightly regulated and tightly controlled, form and function go together. If it's stretched, you'll get dysfunction. So again, it's this whole balance principle. So the Starling equation is if there's more fluid going in or less fluid going out, or any combination thereof, then you're going to accumulate fluid. So it is quite simple, really. You know, again, this is the same Starling thing. Blood flows in and is forced out by arterial blood pressure, and then it's sucked back in due to the protein within blood just drawing by osmosis back into the venules and then going back. So, like in this, and if something is very pressurized, like in the skeezer, it'll seep out. The majority, so that would be something like hypertension. The majority of conditions we see have just got damaged capillary bed, and that may be from inflammation or vascular disease or just congenital malformation. And then the outflow is very much of the venous occlusions. If you dam something, then of course you're going to get a back pressure. And that whole back pressure then slows down flow, then induces hypoxia as well. So just those three examples of high pressure going in. So that's malignant hypertension with a swollen disc and edema and subretinal fluid. This is a diabetic patient with fluid just seeping out. And this is a patient with a vein occlusion. So it's all fluid, which is accumulated in the retina. This one, you've got fluid under the subretinal space. And then in the vein occlusion, there's fluid in the subretinal space as well. So it's the same compartments which accumulate fluid, and it's just recognizing the pattern. And you can say, well, what does that pattern tell us? Because the fluid is exactly the same. But here we've got a swollen disc. Here you also have a swollen disc, but the veins are very tortuous, whereas that's not the case in hypertension. And then in diabetes, it's a microvascular process affecting primarily the inner blood retinal barrier. So that brings us on to the blood retinal barrier, which is, you remember from physiology lessons, but basically the retina's got two blood retinal barriers, the inner, which is the retinal vasculature. So that's the retinal arteries, veins, the capillary bed. Remember, there's a superficial, intermediate, and deep capillary plexus, and they're differentially affected by different diseases. And then the outer blood retinal barrier is the pigment epithelium and choroid. So we've always been taught from physiology that these are the tightest, most well-controlled blood vessels in your entire body. So there's these tight junctions, and that stops leak across the barriers. So again, very, very different. The inner blood retinal barrier is the blood vessel, whereas the outer blood retinal barrier is really the pigment epithelium primarily. But there's an element of the choroid being part of it and Bruch's membrane, and then possibly the outer limiting membrane as well, because that is it's like a sheet of Gore-Tex. If you look at any OCT, you'll never see cystic change or cysts beyond the outer limiting membranes. It's all contained, and you'll never see exudates, which penetrates beyond that as well. It's either going to be in the subretinal space or it's going to be internal to the outer limiting membrane. So that, again, is part of that complex of the outer blood retinal barrier. So it's primarily diseased or damaged blood vessels, but you can get new vessels. Of course, they will leak as well. So in macular neovascularization, classically wet AMD, new blood vessels grow in the subretinal space. They're immature, they leak and bleed, and fluid obviously accumulates primarily in the subretinal space, but then leaches through just as that balance is tipped. And the problem with any protein leaking into the retina is then it'll suck fluid in the wrong direction, because that in itself will just increase the osmotic pressure in the retina. So like any biological process, if you go to the nitty-gritty of the chemistry and the biochemistry of it, there are a myriad of inflammatory mediators and huge cytokine cascades in every condition, whether it's diabetes or vein occlusion or CSR or AMD, as in here. It's got its own cascade of slight variants of various cytokines, and that's ultimately what we're addressing with therapeutic agents. But we're not here to dwell on those. So what is it about the retina which makes it particularly prone? Well, firstly, it's that highly ordered, very regular cell count in that vertical direction. There's something about those columns which then just allow the fluid to, like a sponge, to absorb fluid. There's something about the elevated metabolic activity. It's often said that the retina just functions on the border of hypoxia. So many things can just tip the balance. A slight increase in hypoxia or slight reduction in oxygenation can really upset the balance and cause problems with vision. The other thing is that most of your body, except the nerve, except your brain and the retina, has got a lymphatic system, and the retina doesn't have a lymphatic system. So again, there's a very limited way of reabsorption. We know fluid flows from the vitreous towards the choroid, and there's a sort of active process. There's diffusion as well, but that active process is mediated by the pigment epithelium. So if you've got any outer blood-retinal barrier dysfunction, you're much more likely to accumulate fluid. There is this other thing called glymphatics, which is something relatively recently described in the last decade or so, where part of the pulsation of the eye may be milking fluid back. The glial cells may be milking fluid back towards the optic nerve, and there is this vitreopapillary flow of fluid which goes through the optic nerve head and into the into the brain tissue, the cerebrospinal fluid. Again, another thing about the macula is Henle's layer and this network of axons, which allows fluid to accumulate, and the fact that there's an avascular zone in the middle as well. So right at the center, you have an avascular zone, but we've already said from Starling's law, you need blood vessels to draw fluid out as well. So it's particularly prone to accumulating fluid, which is why it's a site where many, many diseases present. So what we're going to do is just going to rattle through the common causes, which is diabetes, vein occlusions, macular neovascularization, and CSR. Now, those four conditions account for something like 90% of what we see in a medical retina clinic. So then by definition, everything else is rarer. And then, of course, there's a few degenerative conditions which can end up looking a little bit like macular edema, but they're not really that vascular glial process. The retina is sort of falling apart, giving these cystic cavities within, but that's more a different mechanism of development. So you can tell. So as we've said, you can tell an awful lot from an OCT. On one hand, you can look at that scan and say, well, okay, there's a little bit of fluid. It's not particularly thickened. But then when you look into more detail, there's a few cells in the vitreous that could be hemorrhage. There's something going through. Well, looking at that picture, that's neovascularization, because neovascularization always grows out of the retina into the vitreous or onto the posterior hyaloid. There's some fluid there. There's a microaneurysm in that point there. There's little foci, and that could be earlier exudates, or it could be highly reflectile foci, which are macrophages or signs of inflammation. We said before that sort of whole 1, 2, 3, 4 approach of interpreting an OCT, there should be very regular banded architecture, but we can see it's very, very disrupted here. So there's loss of inner retina, there's more fluid here, and then there's disorganization of the retinal inner layers. So that banded architecture is lost. So we know that goes completely with ischemia and non-perfusion. And then we can also say that new vessels grow typically on the border of perfusion and non-perfusion. So that's a single scan, we can just deduce a huge amount of change of the retina. And looking at the infrared reflectance, we see hemorrhages all over the place. New vessels, there's new vessels growing here. So we can tell this patient's got diabetic macular edema, which is both mixed exudative from that microaneurysm, ischemic from that drill, It's possibly a tractional component from the new vessels, and we can go on with that interpretation. So we're going to talk about diabetes in more detail next time. We'll try and make it a bit more case-based next time. But uh, it can be really any any magnitude of edema. So the smallest and most minute amounts is like on this surface map, there's a small area just abutting the central subfield uh, fluid. So we know that's swollen. If we look at the scan, again, if we look at the architecture of the retina, there is fluid within the retina. It is a little bit swollen. So that's a key in looking at macular edema, that it's swollen. So if you've got a cystoid degeneration, where it's a degenerative condition, then you're not going to get red because you're not going to get a physical distortion of the retina. Things cave in essentially. So mostly those scans end up looking blue on the heat map. So again, looking at this picture, it just seems to be a single microaneurysm here, which is seeping out and causing that fluid. And again, when you look at the infrared picture, we can see there's been PRP laser before. And what we know is when you have microaneurysms at the edge of a foveal avascular zone, it inevitably tells us that there's foveal ischemia. So foveal ischemia on this OCTA is an irregularity. So we can see that OCTA is irregular. There's loss of the, so a normal sort of capillary density is like that. We can see it's very rarefied and lost capillary bed there. And then that microaneurysm is that little thing just on the edge of the distorted, widened, irregular foveal avascular zone. So I've put that measurement, 811 micrometers. That's a hugely large, because a normal foveal avascular zone is about 300 micrometers. I'm not sure whether all of you have OCTAs. I know they're creeping into some practices. So the natural sort of progression of that on this scan is that it's the same thing, but just larger. So multifocal, so circinates. So essentially, when something has been chronic, you end up depositing lipoprotein. It's a bit like chromatography. It diffuses out to the furthest aspects. So the biggest proteins travel further, and lipid is precipitated. So you can see on this infrared, there's whites, which is exudate. Exudate has a very bright signal, and the whole retina is a little bit irregular. And that cuts straight through the middle, so it's skirting the edge of these. And then, as you know, you refer these patients in. We end up treating these patients. Our first line is with anti-VEGF. So this is the before and after. You can see that retinal profile has been normalized. This patient did very well with faricimab, just had the loading phase of 4 faricimab injections and was completely dry and maintained that stability for ages. So again, on this scan, it really is just a sort of diffuse engorgement, which is what we said typically happens before the cystic changes. Just the first few cysts are developing, and then it tends to progress into more and more cysts as it becomes more significant in terms of the ischemia. And subretinal fluid is the sort of most severe aspect of diabetic macular edema. You don't see it in most cases, but of course it happens on occasion. And then it ends up sort of being diffuse. More often than not, these patients have got renal disease as well. So remember what we said about Starling's law. If you've got renal disease, you lose protein through your kidneys. If you haven't got protein in your bloodstream, then you haven't got the osmosis to pull fluid back. So one of the first things we often check in patients in clinic is we'll do a urine dipstick in patients with this very sort of diffuse appearance of the back of the eye. So again, looking at the scans, again, lots and lots of changes all over, hyperreflective foci, exudates, cystic changes, lots of irregularity, loss of the banded architecture. But just see where all those cystic cavities develop. It's typically in the in Henle's layer, in actual fact, where most of that first fluid precipitates, and in the so it tends not to be in the nerve fiber layer just because of the organization of that. It tends to be never outside the outer limiting membrane, so it tends just to be internal to that. And then we can look at the characteristics for this. This is a foveal cyst, which is then bled within it. So that patient will have a disproportion, will have an absolute scotoma right in the center of their fovea. And we can tell all these things just by looking at the scan, just the severity of this disease. We can almost guess that this patient will probably have some renal dysfunction as well. It's again a more diffuse picture, and then the key thing to pick up here is a really good example of drill. So where we're looking here, the normal banded architecture of a clearly defined plexiform layer, clearly defined dark nucleated layers is really just all lost there. You've got hyper-reflective foci, and it's just a graying out. So we know the blood supply is poor, and as a consequence of the blood supply being poor, you get cell death. So a tissue doesn't survive, particularly neuronal tissue, which has a very high metabolic demand, without being oxygenated. If you look at this picture, this little cluster of hemorrhage, which you can see on the infrared, is a real key indicator of foveal ischemia. So sometimes you see a patient with diabetes with very little going on at the back of the eye, but you see a few telltale hemorrhages just around the fovea, hemorrhages rather than microaneurysms, and they tend to be an indicator that there's foveal ischemia. And those patients often have a mismatch. So it doesn't look particularly bad at the back of the eye, but the vision is disproportionately poor. So just going on with that continuum of diabetic eye changes, traction is the other thing. So when patients have got proliferative disease, or if they've had hemorrhage, it can often precipitate epiretinal membrane formation. These things can be quite complex, and then it becomes very difficult to work out what's causing the edema. So if we look at this upper image here, we can see there's a bit of VMT, so that will undoubtedly cause some distortion. So you get cystic changes from VMT, but there's also drill, so there's loss of that clearly defined banded architecture. There's some cystic changes, as we said, they tend to form in Henle's layer first. And then if we look at the structure of these membranes, so obviously looks quite complex on the surface map with some neovascular complex there, neovascular complex there, which is then going straight through the middle of the fovea. And remember, the inside of the eye is a curve, so anything pulling in or scarring will pull the retina inwards like a cord, and that will precipitate mechanical edema or stretching or warping. So again, these complexes, and the VR surgeons start calling these changes vitreous schisis. It's not a simple back of the hyaloid. So this is a taut and thickened posterior hyaloid face, very classic chronic neovascularization type feature. And then there's splits and clefts within that vitreous complex, and it's the same here, but just to a greater degree. So we can see here there's a sort of tractional component, and lots of cystic changes within, which has really distorted the profile of the retina. So we'll move on from diabetes to the second commonest, the things we see in our clinic. Number one is AMD, number two is DMO, and number three is vein occlusions. That it really does account for like 85% of what we see. And the commonest sort of vein occlusion to occur is a branch retinal vein occlusion. So they typically happen at the point of an arteriovenous crossing point. So hypertension, dyslipidemia typically precipitate these. So you get hardening of the arteries. That process is arteriosclerosis. Hardening of the arteries, where the vein and artery cross, there's a common adventitial sheath. So the vein is soft and pliable, the artery is hardened, it squashes the vein, so you get turbulence within, and that turbulent flow is prothrombotic and much more likely to precipitate thrombosis. And if you get a thrombosis, then obviously you don't get flow, and as we use that dam analogy, if you create a dam, then you get back pressure on the capillary, and then you don't oxygenate. You don't oxygenate, so the retina becomes hypoxic, and hypoxic vessels leak. And there's a hydrostatic component, there's an inflammatory component, there's a hypoxic component. So there's many reasons why things go downhill in a vein occlusion. So this is a patient who is, again, before and after just one injection, in actual fact. So a hugely hemorrhagic, almost confluent hemorrhage. And again, if you look at the OCT here, apart from the macular edema, which you can see at the center, you see there's a white thing here. So we've mentioned on the OCT talks before that you can get retinal infarcts. When the hypoxia is severe, it can precipitate an infarction. So PAM, which is paracentral acute middle maculopathy, often looks white, or infarcts look white. So a very severe vein occlusion can end up causing cell death. But we always treat these patients. We give them benefit of the doubt. The NICE guidance says that you don't have any visual cutoff. You still try 1 or 2 injections and see, because sometimes you can be surprised. So in this patient, I thought there was absolutely no chance that the vision will pick up, but she went from something like hand movements at presentation and is maintaining about 6/12 now. It's not ideal. There is exudate, which just precipitates out the fovea. So in the long term, that'll be poor. But if you look at the nerve thickness on this, and compared to this side, it is thinned out. So that's inner retinal loss as a consequence of that hypoxia. So it does have its consequences we can control very well with injections, but it's not curative. It doesn't reverse that damage. And this patient was picked up actually and treated within days, but this just reflected the severity of the occlusion at presentation. Here's another one. So again, it can be a bit, again, it's just for pattern recognition. So if you look at we'll just go back to the last one. We said the vein occlusion happens peripherally at an arteriovenous crossing point. So you can see how it's very sectoral, but then the veins going into the disc are preserved. So they still look, well, slightly engorged, just probably because of the hypoxia, but it's still draining blood. And the same with this, it's very it's sort of very quadrantic or sectoral in its appearance. And the edema looks much more diffuse in this case. There's not so much cystic change. There's a few little pockets of change developing there, and there's a few little spots of hemorrhage. And then at the watershed, so remembering the retinal vasculature respects the horizontal meridian, and then normally you don't get vessels. It's a true physiological watershed, so the top half drains the top half, but collateral vessels can open up. There's a few fine capillaries, so you often get tortuous vessels draining off from the occluded area. So again, in this eye, you can see it's very dark. That dark is hemorrhage, and hemorrhage, particularly when it's deep and dark and blocked and confluent, tells us that it's a sort of clinically or an angiographically ischemic occlusion. But we tend to use that definition really for their risk of getting secondary neovascularization. We know BRVO patients do get that. And it's a particular problem when patients have been given anti-VEGF because it tends to completely modify. So we end up, if anyone gets weaned off anti-VEGF, we watch very carefully, often do an exit angiogram just to make sure there's no neovascularization, and do a fair proportion of sectoral panretinal photocoagulation just to minimize the risk of getting neovascular complications in the long term. So BRVOs outnumber CRVOs by 5 to 1, but obviously CRVOs have often a much more devastating impact. This is a very young gentleman who's 37. So our general rule is someone under the age of 40, we will look for hematological causes if there's any thrombophilic tendency, if there's some inherited condition. But the hematology, so that's the Royal College of Ophthalmology guidance. The College of Hematologists say actually there's no point investigating for them because the pickup rate is so low. So really all we're looking for is if there's any evidence of things like deep vein thrombosis or pulmonary embolism or recurrent miscarriages and things, which indicates some sort of anomalous clotting state. So this is CRVO. We said, well, at this stage, with secondary PAM, this whitening, it's a little tiny pocket of fluid, but and if you look at this color map, we can see it's all very engorged. You don't normally see the reddish colors. So we do know, and as we've said, that could be just a diffuse engorgement from the back pressure. It could be cytotoxic. So again, there's different types of edema. You can get vasogenic edema, which relates to what we've said, the hydrostatic pressure rise, and that's blood vessels leaking. Or you can get cell death, where the actual cells swell rather than fluid within. So there's an element of that where this patient's got a lot of whitening, that back pressure and that slow flow through the capillary bed. I mean, that's what a vein occlusion ultimately does. It reduces the drainage, so the retinal tissue, which is metabolically active, is not oxygenated. If it's not oxygenated, then without question, it ends up tipping the balance into cell death. So the clues were there. This guy's going to have a bad prognosis. And then, we normally tell patients if they haven't got frank edema that we wait on it and we'll bring them back a month later. And the natural history is 1/3 of patients will decompensate, 1/3 of patients will sort of hold a steady course, and 1/3 will end up getting a spontaneous improvement and recovery. Anyway, this patient came back a few days later with a gross decompensation. So that all looks pretty bad. I mean, we have started treatment, but it's been pretty futile in his case because he hasn't really recovered. That's not the same case. So this is another case of a vein occlusion, and it's really just to show that back pressure causes a huge general engorgement. So that nerve tissue, if you look at the metrics here, it's 424, 433, 421, 447. Normal retinal thickness in the middle is about 280, well, 220 to 280. That's 464. And these surrounding areas are usually 280 to about 320. So there's a huge increase in the retinal thickening. There's a little bit of subretinal fluid, as we've said. That's what happens. And then this patient, obviously with anti-VEGF, does amazingly well. Now, central retinal vein occlusions have got the highest levels of VEGF production. So they do traditionally respond. They often have a very dramatic appearance. VEGF is a permeability factor, so it causes diffuse capillary bed leak. And of course, if you block that signal, you get a rapid resolution. So more often than not, most patients with vein occlusion within 1 or 2 injections will end up looking relatively anatomically normal. Whether the vision picks up just depends on how much damage was done at the time of occlusion. So macular branch vein occlusions are often seen. They're often a source of difficulty in diagnosis as well, because you haven't got that classic widespread appearance. And often it's diabetic patients who get these, so then it's difficult to distinguish, is it the diabetes causing it? It's just that whole general vasculopathy, that risk of hypertension, dyslipidemia, which inevitably go hand in hand with diabetic patients, or and dyslipidemia and hypertension account really for vein occlusions for about 90% of what we see, particularly for branch vein occlusion and macular branch vein occlusion. And the problem is it's a small tributary, but the effect is pretty much the same. It's still very central or foveal edema, and then that will end up causing a disproportionate impact on vision. So the relative area is small, but the symptoms are still profound, because obviously the most important bit of your macula is the center. If you accumulate fluid in it, you will get dysfunction, which untreated just causes progression. So again, you can see on the infrared reflectance, there's lots of little spots of hemorrhage. It often follows just the territory, so it's very, very territorial. So you can see that beyond that venule and beyond that venule, there's very little. So it is confined. So the other tributaries still continue to drain in their normal pattern. And again, they typically do very well with treatment. This is a different case, and again, it just shows how minor these things can be, and it is quite variable as to how symptomatic individual patients are. This patient was actually symptomatic with this tiny little thing. So again, we end up having a risk of a discussion about risks and benefits. So when someone's vision is still better than 612, we'll often give them the benefits of the doubt. If they tighten up their hypertensive control, that's the pressure head driving fluid out. As we said, 1/3 of patients, or 2/3 of patients will be stable or spontaneously improve just with improvement of their systemic disease and systemic control. So make sure the blood pressure is well controlled. We'll often recommend real tightening of the blood pressure and cholesterol, because one other sort of medical statistic is the risk for heart attack, stroke is the odds ratio is 50% greater in the year after someone's had a retinal vein occlusion. It's just an eye indicator of a systemic problem. So these patients are much more prone to heart attacks, strokes. And so we tell these patients to go back to their GP and often have a 24-hour blood pressure monitor, having fasting cholesterol, and then check their other vascular risk factors. Hemiretinal vein occlusion is probably the least common out of those. It sort of depends on the anatomy of the vessels as they leave the optic nerve head. Essentially, they're treated the same as a central retinal vein occlusion, particularly in their impacts. And if again, this in terms of the pattern recognition, the fluid goes straight through the disc because the occlusion is at the level of the disc. There's a central retinal vein which breaks into a superior and inferior branch before it goes into nasal and temporal branches. And so if the occlusion is at that major superior and inferior bifurcation, then you'll end up with a hemiretinal vein occlusion. And then they often have quite a profound impact on vision. And from our perspective, we treat them the same as a central vein occlusion. So again, there's another one with the same sort of picture where the edema goes through the disc. I mean, there's a general engorgement because the disc often swells. So there's a little bit of back pressure on the superior draining vessel as well. This patient's obviously quite chronic. There's a bit of a macular star going on. So again, on a superficial glance, it looks like there's edema across the entire macula, but on a closer inspection, we can see that actually the major dilatation is just in that inferior vessel, and all the hemorrhage is just confined to that inferior hemisphere. Superiorly, there's no hemorrhage at all. So again, it's that pattern recognition, which tributary is affected, and that'll sort of point you in the direction of which particular vessel is blocked. So again, the importance of the distinction is the majority of branch or macular tend to be related to hypertension, dyslipidemia, and they're at an increased risk of heart attack and stroke. So it's important to tease that out and make sure they get the systemic workup by their GP. So we won't dwell too much on macular neovascularization. So as you remember from last time, macular neovascularization is now the correct term for new vessel growth at the macula. It was called choroidal neovascularization, but the sort of conventions have moved on. And this sort of encompasses all those things. So this is primarily, again, the pattern recognition will show us that that edema is often associated with something happening in the subretinal space. So we talked about type 1, type 2, type 3, type 4 neovascularization. All depends on the position, whether it's under or in front of the pigment epithelium. And this looks like very much like a wrap lesion. So we can see there's a PED with a little stalk of something going through, and then edema. So the classic appearance of a wrap is a small intraretinal hemorrhage, florid edema, which doesn't typically happen with AMD, but can find, and it often you see a little penetrating or perforating stalk going through a pigment epithelial detachment. And then, of course, you end up looking for other features of AMD. So in this cut, there's very little. The rest of the image just to show there's a few drusen elsewhere. So the most likely cause would be AMD in the majority of neovascularization that we see, but there's plenty of other causes, and it depends again on the ethnicity. So Black patients often don't have drusen, but can get things looking like polypoidal vasculopathy or wrap type lesions. And then a much more profound, so again on the picture, it's very localized. The center of the edema, this is where that cut is. So we can see there's a neovascular complex between the pigment epithelium, which is there, and the retina. So that's most likely to be a classic or a type 2 neovascular membrane in the subretinal space. And they tend to have more subretinal fluid and intraretinal fluid. The occult membranes under the pigment epithelium tend to be slightly lower grade, but of course it all depends on the extent and severity, and you often get mixed components from these membranes anyway. So again, the things we pick up on this OCT is we'll see evidence of little subtle drusen. On this scan, we see lots of reticular or subretinal drusenoid deposits, which are drusen in the subretinal space. And then, of course, there's edema with subretinal fluid, intraretinal cysts, and the neovascular complex, and a thin choroid. So often with AMD, you get a thinner choroid. So CSR, we don't traditionally think of as a condition which gives macular edema, because typically the fluid is confined to the subretinal space. But it's that distinction between acute and chronic, or simple and complex. So the more chronic and persistent CSR is, the more likely you are to develop intraretinal cysts, or cystoid degeneration, as it's called. This particular appearance, if you look, remember what we said before, that we're looking for features of a thickened choroid. So the normal choroidal thickness is about the same thickness as a healthy retina. This choroid is thickened, and if the choroid is differentially thickened between the subretinal, between the subfoveal thickness and the disc, it's something called a peripapillary pachychoroid syndrome, which is a variant of CSR, which is sort of notoriously difficult to treat. And they often present with intraretinal cystoid degeneration. So you can see this looks pretty grim. They do sometimes respond to PDT despite them looking so bad. But when it gets to this sort of stage, our sort of understanding of the pathophysiology is it's probably been there 3 or 4 years before it gets to this stage. So, we prefer not to let people get to this stage. PDT works best if you undertake that treatment. Photodynamic therapy works best if you undertake that treatment within the first 6 to 9 months of presentation. This is another CSR patient, and in this case, it was due to lupus, which induced a nephropathy. So he'd been on long-term steroids for his lupus. And as a result of the steroids, developed CSR. There's nothing you can do about it because he's got a life-threatening disease. You can't stop his steroids. And then because of his nephropathy, he was losing lots of protein. So he suddenly went into more advanced stages of renal failure. And that corresponded. There was a nice example of how if the on Starling's law, if the albumin is lost, you can't draw fluid in. We see this in diabetic patients as well with hypoalbuminemia. Then patients end up getting edema from a different metabolic pathway. So again, you guys who are on the MEX pathway may end up seeing this post-operative inflammation. So we're talking about the sort of rarer causes now. It's relatively uncommon. So in these days, with phaco, the rate of post-operative edema is about 1 to 2%. It does still happen, often with denser cataracts, but certainly with diabetic patients, the rate hugely escalates up to somewhere between 25 and 30% of patients will get some sort of transient breakdown in the blood retinal barrier, and even more so if they've got pre-existing diabetic macular edema. So our first line approach is drops alone. We have a very standard approach, drops for a month. If it doesn't work, then we'll either use a posterior subtenon steroid, or depending on what other co-pathology there is, sometimes an intravitreal steroid. But the vast majority of these settle down. Very unlikely for patients to end up needing surgery. So I think the general rule is 90% settle with drops. Of the 10% who don't, a steroid injection, whether that's posterior subtenon or intravitreal, will get rid of 99%. But there'll be 1% of patients who have tractional problems, or some sort of vitreomacular traction or co-pathology, who end up needing epiretinal membrane peel or surgery. So epiretinal membranes are often strongly associated with post-operative macular edema. It's particularly problematic in patients with who have had a vitrectomy, because the treatment, none of the treatments seem to work that well. So we end up going into these patients straight with Osidex injections, and it's a little bit hit and miss as to whether they get cured with a single Osidex implant or whether they need repeated treatments. We have a certain cohort of patients who, years down the line, when they decompensate, just end up needing. And it's all part of the sort of blood retinal barrier breakdown from whatever's happened in the past, often post-retinal detachments, as was the case in this patient. So uveitis, along with, we can sort of lump this together with post-operative inflammation. So post-op cystoid macular edema, or Irvine gas syndrome, or any of the uveatides, whether it's just acute anterior uveitis or any of the posterior uveitis, whether that's retinal vasculitis or whether it's an infective cause of uveitis, or one of these idiopathic intermediate, or some of the rare sort of genetic related things like birdshot, they all seem to end up having a breakdown of the blood retinal barrier. We know about the very complex pathway of this cytokine cascade in uveitis and how that tends to cause widespread leakage. If you look at the OCT, you can see lots of cellular material in the vitreous. So that's a little bit of a giveaway in these uveitic disorders. You look and you'll often see vitreous cells or the vitritis as part of it. And of course, you know, that it's the story and the history will tell you most of it. But intermediate uveitis tends to be completely idiopathic in most patients, but they tend to have central edema. But more often than not, in the peripheral retina, there'll be some sort of vasculitis and evidence of periphlebitis, and certainly an angiogram is absolutely pathognomonic. So in these uveitic patients, we often do an angiogram to work out the nature and extent of not just vascular leakage, but peripheral shutdown and whether there's any neovascular complications. But often, depending on whether it's the arterioles or veins affected, it'll sort of point us towards what the underlying diagnosis for the uveitis is. Another problem which happens often enough, and again, these are sort of weird and wonderful and rare, but on a weekly basis, we get multiple patients coming through with Coates disease or on any of its variants. So Coates disease is a failure or malformation of ocular vasculogenesis. So there is thought to be a genetic tendency for this, which partly explains the male to female ratio. We know it's something like 80–90% of males affected, but we have enough women come through clinic. There is a particular gene called Norris disease is entwined with retinopathy of prematurity, FEVR. So we know it's an integral part of how blood vessels form in as an embryo, and that sort of disorder change can cause abnormal blood vessels. Now, the mystery about Coates is it can be the entirety of the retina presenting early, or we see patients in their 70s and 80s who we diagnose Coates disease, and then we don't know what the trigger is for decompensation of these abnormal vessels. But the absolute sort of pathognomonic appearance is these sort of filigree pattern, little aneurysms, and lots of capillary non-perfusion in between. So this patient was very quadrantic, but actually when we do an angiogram, we often see patches elsewhere. And then these blood vessels, so this was an 11-year-old child who actually lasered, and he's done amazingly well. He was pretty brave to be lasered as an 11-year-old, but we've controlled him, and for the last 2 years, he's not had any further laser treatment. But these patients need lifelong review, and we say we'll end up doing laser on average once or twice a year because new little microaneurysms will pop up and leak. But the vast majority of patients we can control with focal and grid laser really very effectively. Occasionally, we do Ozurdex implants if the edema is bad, and that seems to be pretty successful too. So juxtafoveal telangiectasia, there's historically 3 types of juxtafoveal telangiectasia. They were sort of incorrectly lumped together just on clinical findings, but our understanding has improved with OCT. So this is really on the Coates spectrum. It's really the identical changes angiographically. It's still microaneurysm, still capillary non-perfusion, and it's still this filigree pattern of blood vessels. So angiographically, they look identical to Coates disease. And JFT type 1 is where it's just next to the fovea, Leber's miliary aneurysms, where it's a little bit more widespread in the mid-periphery, and Coates tend to be just much more diffuse across the retina. So we treat these patients the same as Coates disease. We laser any microaneurysms that we can see. And this is the same patient before and after laser treatment. I think I lasered this patient just 3 times about 5 years ago, and he's been very, very stable. We will still continue to monitor long term, and it's a little bit variable. Some patients we do dual treatment with anti-VEGF agents as well. Anti-VEGF tends not to work so well, so we do anti-VEGF first. Some are responders or non-responders. We use Avastin off license, and then Ozurdex seems to work quite well, but a lot of these patients are young, so it's not our first choice because of the cataract and glaucoma risk with repeated Ozurdex. But often it just allows some of the edema to settle down, it increases the visualization of the aneurysms, and then we end up just doing more laser. But as I say, it's something which is a very chronic process. It's probably just blood pressure which drives these already formed aneurysms to then just balloon up and leak further. And then again, if you look very closely, you can see the little aneurysms or aneurysm dilatations within the retina. And again, laser just seems to stiffen them up, scar them up, and eventually close them and stop the leak. This is a macro aneurysm. Again, in a diabetic patient, so this patient was incorrectly diagnosed in clinic by one of our casualty officers as having diabetic macular edema. Now, this is important because if the patient is misdiagnosed, again, the pattern of leak, there was a spot of maximal thickening. So when we just run the take the OCT through it, we can see there's a sort of anomalous structure there. And it's where that, it's pretty much where that cotton wool spot is, but it's not the cotton wool. There's two things going on. There's a cotton wool spot, which is at elevation in the nerve fiber layer, but there's a deeper ovoid structure there. So again, there's two or three things going on here. This patient's got significant hypertensive changes, all the little splinter hemorrhages and flame-shaped hemorrhages. They've got diabetes and blot hemorrhages and cotton wool spots, all suggesting suboptimally controlled. And then macroaneurysms tend to be the manifestation of chronic hypertension. So again, it's the pattern of leakage. There's little bits of exudate around. It's just a focus of leak. So in a macroaneurysm, we just zap them with a laser and they will just disappear. Now, if it's diabetic macular edema, they'll get enrolled onto a course of anti-VEGF agents, and the average DMO patient gets 8 injections in year 1 of Eylea, probably 5 injections in year 2, 3 or 4 injections in year 3, and it goes on and on and on. So the correct diagnosis is really important. But this was misdiagnosed in our department as well. But when they came through to the MR clinic, we spotted that and just zapped them with the laser. So do once. And macros respond really very well to focal laser therapy. Radiation is really quite unlikely, but we're just sort of throwing it out there as all the other things. It creates a microangiopathy. So to all intents and purposes, it's exactly the same as diabetes. So there is a sort of classification as to whether it's extramacular, macular, or macular edema, or neovascularization as to what stage you've got. This patient, you can see, had a dark black mass, and then they had a plaque put around it. So that plaque has just destroyed the tumor and everything else around, because we're just looking through to bare sclera. But this is the late complication. And radiation retinopathy can kick in anything between 18 months to 10 years afterwards. Typically, it's 2 to 3 years afterwards. And it's a real nightmare to treat because more and more changes continue to evolve. But our first line tends to be, if it's early, again, anti-VEGF. Steroids work very well, but focal laser works very well because the sort of defining feature is often microaneurysms which leak, but eventually these patients end up getting capillary non-perfusion, and a lot end up getting neovascularization, in which case they'll just end up getting heavier laser. So this is hypertensive retinopathy. I think I put this picture up right at the beginning. So if you look at the color picture, it's a sort of grade 4 malignant hypertension. What you see is disc swelling, so papilledema. So that's a medical emergency. They have to go to the medics for stabilization. But if you look at the features, it's not dilated veins, but it's constriction of the arterioles. So what you get is in younger patients who haven't got arteriosclerosis, true hypertension causes focal spasm. There are muscles within the arterioles and they go into spasm. So the arterioles look narrowed, the veins look dilated, but it's just a relative dilatation. And then cotton wool spots and splinter hemorrhages and exudates as a feature of chronicity. And really, these will just settle down as soon as their blood pressure is controlled, but it has to be medically done in a very controlled manner. Too rapid a reduction can cause hypoperfusion and cause catastrophic optic nerve problems as well, and wipe out the optic nerve head. So that's sort of going from hypertension to hypotension can cause an anterior ischemic optic neuropathy. Drug toxicity is probably too wide to talk about. There's a colossal amount of drugs that can cause macular edema. We tend not to use epinephrine too much, but in terms of cystoid macular edema, it's just a handful. Nicotinic acid is rarely used in the UK. It's the cancer doctors these days who, and the sort of neurologists using immune agents, which are causing us more and more problems. So this patient came through just everything at the back of the eye. This was an ovarian cancer patient who didn't have metastases, but some of these MEK and BRAF inhibitors are really quite induce huge serous retinopathies. The choroid becomes very, very engorged, subretinal fluid develops, intraretinal fluid develops as a diffuse engorgement of the retina. And then we just ask them, there's often a uveitis with us as well, so we'll put them on some steroids, ask the cancer doctors to either give them a treatment break, in which case things settle down, and then reintroduce the medication at a lower dose. And usually that controls the issue. So we're seeing that more and more. One of the problems the glaucoma team tend to cause us is with hypotony. So it can be other things in terms like injury and VR surgery and things as well. But we see disproportionate amounts of patients who have had glaucoma filtration surgery if they're overdraining. And this is the same, essentially the same as high blood pressure. It's not the blood pressure being high, but it's the intraocular pressure being relatively low, then has a disproportionate effect of the perfusion of the arterioles. So everything becomes very, very corrugated and edematous at the back of the eye. And then if that is managed, whether that's by injecting viscoelastic device or putting a suture in the tube or closing whatever defect is leaking, that tends to settle down fairly quickly. Um, as usual, I'm running out of time, so I'll whiz through the last few, but there's not too many more here. Tumors rarely metastasize to the eye. Tumors typically cause leakage as well, so subretinal fluid. The clue here is there's a great big mass in the choroid. So again, it's just that general look, because on a cursory glance, that pigment epitheliopathy can look very much like a CSR type thing, but it's looking at the choroid. So again, the similarity is the subretinal fluid and cysts in the papillomacular bundle and a thickened choroid, but the shape of the thickened choroid is an elevation into the eye rather than a general thickening. And this is a lady who had ovarian metastases into the eye, and that just ended up looking an absolute mess. So that's a outer blood retinal barrier dysfunction when the choroid and pigment epithelium become damaged. Chemotioretina used to be called Berlin's edema. It's really a shearing of the photoreceptors, so it's not really edema at all, and it just settles very, very rapidly. Depending on the severity, it depends on how bad the visual function is. So it's worth dwelling a little bit on the degenerative causes, which can end up looking like edema, but aren't edema. So we see degenerative microcysts in patients with advanced glaucoma. So if you look at this scan here, there's no nerve fiber layer. That if we remember back to the first talk we did, the first thing you look at is the foveal depression, so it looks blunted. There should be a thick white wedge of nerve fiber layer going into the optic nerve head, and then this is a secondary degeneration, and this is a little bit more internal, so it's not in Henle's layer, but it tends to be in the plexiform, in the bipolar layer, in the outer sorry, the in a nuclear layer. Same on the other side of the same patient. This patient had an optic neuropathy. So we get these in optic neuropathies after silicon oil glaucoma patients when there's advanced glaucoma, vitamin B12 and folate deficiency. There's a number of conditions which end up with these degenerative microcysts. Visual macular traction, of course, can look like macular edema as well. And this is a mechanical pull. So as soon as a mechanical pull is relieved, things tend to settle down. But that's one for the vitreoretinal surgeon. So this is mechanical pressure. And it's the same with myopic traction maculopathies. Again, this irregular curvature of a staphyloma, which can be of various complexity at the back of the eye. It's a complex interplay between the vitreous. There's often vitreous schisis as well. And then that retina and its very poorly supplied choroid, particularly in that curvature. The definition of a staphyloma is an irregularity in the radius of curvature of the inside of the eye. That curvature lends itself to just splitting and excavation. And it typically starts just at the border of a staphyloma. So again, in this cut at the edge of the staphyloma, we see this myopic macular schisis, and they all come under this guise of myopic traction maculopathy. So it's another one for the VR surgeons to consider whether they're stable or unstable. They'll do something about it, whether that's a buccal or a vitrectomy. A real weird and wonderful, but we have got a collection of these sniffers, which is stellate non-hereditary idiopathic foveal retinoschisis. So they look like retinoschisis, but they're not retinoschisis. Sometimes there is a cult traction somewhere or other, and sometimes it's absolutely nothing identifiable. They're completely angiographically inert. It's a very, very characteristic appearance where it's just absolutely torn apart at Henle's layer. So again, it looks horrific, but these patients actually have amazingly good vision despite that ridiculous appearance. Sometimes scleritis can end up causing these problems. Typically, it's more subretinal fluid and corrugation rather than edema as such, but any inflammatory disorder at the back of the eye will cause edema. And then just coming up to the last 2 or 3 cases, disc pit maculopathy, again, when there's a communication. So again, look very closely at the optic nerve head. You often see this little defect, which then communicates into the subarachnoid space. And we don't know what the cause of the fluid is, but these are, again, one for the VR surgeons. What they do is a vitrectomy, often stuff a bit of ILM into the hole, and that seems to get rid of the problem. We don't do laser barrage or anything anymore, but it all depends on whether that's progressive or not. But if someone's got subretinal fluid or progression, the VR surgeons will intervene these days. The thing I see in my genetic clinic is a lot of the retinal dystrophies, so rod cone dystrophies or RP, and you can see on this scan, you can diagnose RP because the outer nuclear layer or the photoreceptor nuclei just completely attenuates. The ellipsoid line completely disappears, the outer nuclei disappears, so we know there are no photoreceptors outside the fovea, and that whole the retina is just so disorganized that the interphotoreceptor matrix binding proteins have all just disappeared as well. So it just falls apart. And this is a patient with choroideremia. So it's not completely restricted just to rod cone dystrophies. And we always try Trusopt in these drops for whatever reason, which is completely unexplained. About a third of patients respond to Trusopt drops, and it gets rid of the cystoid, and that form and function just preserves vision and sometimes enhances vision by a line or two. Same with X-linked schisis as well. So these are 2 separate patients, but cystic cavitations, this is just nerve tissue. So this is there's a protein called retinoschisin, which is a photoreceptor structural protein, which isn't formed. So the matrix isn't there of holding the cells together. But again, for some reason, some of these patients do respond to Trusopt, and you can see this patient's got a round detachment down at the bottom, but still had some degenerative change at the fovea, which is the commonest place to see them. And then the very last case is type 2 juxtafoveal telangiectasia. Originally, this was lumped together with type 1 JFT. Type 2 is typically bilateral. Type 1 is usually unilateral. But we now know this is a Muller cell disease and a neurodegenerative condition. So Muller cells decay. And what we see is thinning of the retina. So what we said is these maps tend not to be red, even though you see cystic cavitations. This is just really the nerve tissue disintegrating on itself. And the blue infrared reflectance is really pathognomonic for type 2 JFT. And an OCT scan, it's just this inner limiting, this ILM drape. So you just see a little thin membrane overlying cystic cavitations, and you get a total disruption of the ellipsoid line and the outer limiting membrane as well, which tells us that this is very typical. And looking in, you'll see little dilated venules and right angle venules and sometimes crystalline changes, or suggesting that there's edema or a vascular process, but it's not. It's a sort of neuroglial degeneration. So we've whizzed over ridiculously quickly, 5 minutes over again, with the common causes: diabetes, vein occlusions, neovascularization, CSR. That's 90% of what we see. And there's lots of rare, weird and wonderful things. And it's just the history and the pattern which will normally point you in the right direction. But always be on the lookout and think about degenerative masquerade conditions. Really, any patient with macular edema has got a problem. So they all should get referred in to the hospital service, unless it really is a truly chronic, non-progressive change. In terms of a treatment option, it all depends what it is. If it's a systemic thing, well, of course, improve systemic control. That really goes particularly for diabetic patients and hypertensive and dyslipidemia patients. And then we've got a whole armamentarium of changes and of drugs that we use, anti-VEGF steroids, whether that's drops, subconjunctival, subtenons, intravitreal, or depot. Non-steroidal drops we use, again, in post-op inflammation and uveitic inflammation, carbonic anhydrase inhibitors, Trusot, etc. Sometimes orally for RP patients, often as Trusot for retinal degeneration patients, and then laser depending on what the cause is. If there's a very defined and definite focus of leak, we'll often zap it if that's what an angiogram dictates. Surgery is really preserved for those actional conditions, and more often than not, we use some sort of combination. So I'll stop there. One day I will stick to time.
It was amazing. Thank you so much. It was quite in depth and really useful. There are two questions really. One in the chat, if you wouldn't mind. It's regards to Irving gas. So some providers tend to give patients non-steroidals for a few weeks before the op if the patient is diabetic, and this is for cataract treatment for phaco. How do
Yeah.
these work physiologically to reduce and prevent edema?
Yeah, I'm not convinced that they do in actual fact. The cost benefit, Nepafenac, which is was been heavily pushed by the reps, hasn't really clearly got any true benefit. We've sort of stopped using it at St. Thomas's just because we were dishing a hell of a lot of it out. And the numbers needed to treat were you have to treat a lot of patients to just save one cause. It's an expensive drug. So our approach now tends to be is we will see patients in clinic if they've got diabetes for an OCT. And if there's any sign that macular edema is worsening, then we'll give them the non-steroidals at that point, but there's no sort of standard accepted convention. I don't think there's any good solid evidence that starting a week early, 3 days early, a month early, all these permutations and combinations, but have been tried. I mean, we run a course at Euretina, the biggest sort of conference for retinal specialists, on dealing with macular edema, diabetes in cataract patients. And again, our sort of message that we send out tends to be treat it if it develops, because it's about a third, 25, 1 in 4 to 1 in 3 patients will end up decompensating. Most of them is just due to the inflammation, and most will subside due to. So again, things have changed with anti-VEGF, but there's no substantial evidence. And again, US data. There's a big study from Kaiser, which is a big healthcare provider, which looked at 10,000 cases or so, and they said there's just no evidence to say it makes any difference. So that sort of big data is helpful rather than clinical trials. But the sort of Nepafenac trials were really poorly constructed trials. It's a bit of a theme in medical retina, bad trials and then disproportionate reporting by drug companies to say the merits. So again, the patients don't like it because they have to take more drops. There's no convincing evidence. I think our approach is very much see patients 2 to 3 weeks post-op and then another review 2 months after, because typically post-op macular edema kicks in 2 months later. It's when the steroid gets weaned off. That's the time to watch them carefully and then hit it hard. I say 99% of patients with either drops or a so again, it's the timing. The reason people go wrong is they let it linger and then it becomes chronic. And anything which goes chronic is difficult to treat. So we in St. Thomas, in my clinic, we give a month of drops, and if it hasn't resolved, we'll give a subtenon steroid injection. If there's a lot of diabetic change which pre-existed, we'll probably go straight to our Nosodex implant. And a lot of patients I treat, if they've already got clinically significant macular edema, if they're on anti-VEGF, we'll give them an Osidex at the time of cataract surgery. So being a bit more proactive about it.
Thank you so much. The second question, I think, is more of a broader question, and it was really to do with the point that you raised is that if there is macular edema there that is not stable, but is showing evidence of change, that you would like to see it in clinic, it should be referred on. The thing I'd like all of us to understand better is what needs to be dealt with. We have two pathways, an urgent pathway, which ideally is seen within a few weeks, and a routine pathway, which ideally is seen within 3 months. What is it that hits the urgence?
Acute onset. So diabetes is a slow-moving disease. So, I mean, it all depends on the severity. The only sort of urgent thing that needs to be referred, and again, the medical evidence doesn't really back it up. The national pathways for PDR is refer and treat within 2 weeks. In actual fact, that's not substantiated by the medical evidence. There's no better outcomes by delaying treatment. Not that I'm saying you should delay the treatment. Our guidance is the guidance. These patients are in trouble. But diabetic macular edema is a slow-moving disease. So, they've got to that point because of years of suboptimal control. Seeing them in 4 weeks or 4 months realistically is going to make very little difference. Um, but it's such a wide ranging beast. So you have to be absolutely certain that there's no co-pathology like a vein occlusion, which is masking, or tractional pathology, which may be on the point of really decompensating, having an adverse outcome. So the ones that really need to come in urgently are vein occlusions, without question, because the sooner you pounce on them, the more likely they are. Neovascularization, of course, has got to be treated pretty urgently. CSR is a slow thing to get cystoid change, and that's 90% of cases. So the diabetics, again, depends on the severity. If it's really gross center involving treatment, then of course there is a window of opportunity, but that window of opportunity for anti-VEGF lasts about 18 months to 2 years before it goes into chronic disease and steroids. National guidance may dictate something, but practically and on a sort of physiological and a pathophysiological level, that's the way it is. But diabetes is a really, really slow-moving condition, so delaying by a short amount of time. So any acute pathology, vein occlusions, arterial occlusions, obviously should get sent in.
Yeah, brilliant. Thank you so much. Thank you so much for this today. I'm just going to stop recording.